Hello, everyone. I will share my screen. I am Maria Gustafsson-Trakowska, the editor of the Bulletin of the World Health Organization, and I have been the handling editor of this theme issue. Thank you, everyone, for joining this launch of the special theme issue on the lessons for effective COVID-19 response. For all you listening, if you have any questions, I would like you, it would be great if you can type them so that we have them for the question and answer session later after the presentations. To start with, I just would like to present the bulletin and what this journal represents for you who's not that very familiar with it. So the bulletin is a monthly peer-reviewed journal of public health with a special focus on developing countries. Journal is a fully open access with no article processing charges or author fees. And articles are published in English with the abstract in 6 official UN languages. Just for clarification at this moment is that the journal is not listed in the directory of open access journal because the WHO website is currently migrating, as you might know when you are in the WHO general website. But as soon as that is done, we will be also listed there. But just remember, we still fully open access. So I just wanted to just crunch some numbers for you here that for this theme issue that was started April last year with a call for papers, it has been over or almost 70 submissions. And about 25 of these has been peer reviewed of the first screen. And 15 was invited to submit a revised version, and we have accepted 10 paper of 9 is published in this theme issue, and 1 is in the upcoming theme issue. And this theme issue will be available at the Bulletin's website as soon as it's linked with the PubMed content. But all the articles is still now online ahead of print version. But I'm hoping that it will be up to date, the printed version online. So this theme issue, as you can see from this map, is covering articles across the world. Most of these papers are on maintaining health services, anything from eye care to tuberculosis care, as we will hear later, and so forth, and also the policy responses. We do have 2 papers looking at child health and how that was affected by the pandemic, both in vaccination and hospitalizations. We have 2 papers on equity. One is the editorial, not listed here, on equity in the pandemic response, but also a paper from the United States describing how the CDC has tackled the fact when the inequities was revealed during the pandemics. And we have a paper from Italy, basically lessons from the field describing how they use indicators to tweak when calibrating their restrictive measurements and what they learned from it. You also on this slide see a picture of Uche Amatsigo. I hope I pronounced her name correctly. She's an expert in neglected tropical diseases. Her in this issue about how the community-based treatment and so forth has been affected during the pandemic. You also see a picture of a mobile health clinic, and we have a news feature on how mobile health clinics has been used during the pandemic, but also in conflict setting and so on. And with that introduction, I would like to give the word to Dr. Jessica Scherer, where she will discuss her paper on the policy tracker. Thank you very much.
Thank you, Maria. Good evening, good morning, good afternoon, everyone. Let me share my screen. Okay. Thank you so much for the invitation today and for this exciting opportunity to be a part of the special issue on lessons learned from responses to the COVID pandemic. As Maria mentioned, my colleagues and I from PATH, we early in the pandemic, we became quite interested in national policy responses to the maintenance of essential health services. And so today I will be presenting some work that we did to document national policy responses, analyze the content of those policies, and understand exactly what was happening, and then lessons learned from that. So as we are all aware, COVID-19 has disrupted the delivery of essential health services, and we are seeing the disruption continue even now. There have been many measures to maintain essential health services, which I will talk about throughout this presentation. But very, very early in the pandemic, there indeed was great concern that the pandemic itself could cause the disruption of essential health services. And so in March of 2020, the World Health Organization began work on guidance, global guidance to maintain the delivery of essential health services. And there were two iterations of that guidance, but similarly around that time, quite early in the pandemic, national country governments and policymaking bodies also started thinking about their national policy responses to maintain essential health services in the face of the COVID pandemic. And as I noted, we were observing the development of these national policy documents and became quite interested in collating them in order to share them across countries, but also in order to learn from them. We ultimately identified 198 national policy documents. Now, these were not from 198 countries. Many countries had multiple national level policy documents describing or making recommendations related to the maintenance of essential health services. For example, a given country could have a document on maintaining malaria health services or HIV health services, as well as maternal, newborn, and child health services or immunization services. So the total of 198 documents came from, I think, about 50 or 60 countries themselves. So within these documents that we reviewed, we looked at the documents to see, first of all, what they said about the maintenance of essential health services. We coded the recommendations and the policies, whether or not the policy said that the service should be adapted, continued with infection prevention and control, or paused or suspended. So for example, an example of adapting an essential health service would be recommending that that service be shifted to telemedicine, for example, or recommending that an immunization service be delivered at a school-based setting to avoid infection in the health facility. And then continuing with infection prevention and control, as you can imagine, simply recommends this service should be continued in its current form of service delivery, but with additional infection prevention and control. And then finally, there were a small number of services or a small number of policy documents that recommended pausing or suspending an essential health service, particularly in the early stages of the pandemic. And this pertained generally to immunization campaigns and school-based health services. And some of these policy recommendations were later reversed when it was realized that the pandemic would last for longer than weeks or months, and that these services could not be paused or suspended indefinitely. So you can see the percent in this table here of policies we reviewed that made each of these recommendations. So you can see that the majority of policies recommended adapting services and continuing services with infection prevention and control. We were particularly interested in our content analysis of these policies, not only what they said at a high level about maintaining the service, but when it came to adaptations, we were very interested in which types of adaptations they recommended. And in our review of the policies, we identified these types of adaptations that you can see here. So common examples included appointment scheduling. So for example, when previously a service did not require appointment and clients just walked up, appointment scheduling was introduced to mitigate overcrowding in health facilities. We also saw many recommendations in these policy documents related to integration at the point of care, so that if a client was coming in for one health service, it was recommended that they be able to receive multiple services at the same visit, again, reducing the number of visits that they made to the facility and reducing overcrowding. We also saw examples of telehealth recommendations. Multi-month prescribing was another very common one. Task shifting to lower levels, self-care by patient. So you can see a number of different service delivery adaptations that were recommended throughout these documents. Now, what we were also very interested in as we reviewed the content of these national policies, and we noticed many of these different types of adaptations, we also became interested in whether or not the policy documents gave operational guidance on how to implement these adaptations, because some of these adaptations required somewhat significant shifts in the health system, in the organization of care, the delivery of care, financing, or human resources requirements. So we reviewed the policies and coded policies according to whether or not they mentioned some of the health system's building blocks. And of course, while most of them discussed or mentioned service delivery in many different ways, there was a much less frequent mention of some of these building blocks that would be required to actually implement some of the adaptations that were being suggested. So you can see across the documents that only 45% of them talk about health workforce, 40% talk about leadership and governance. If we go down to healthcare financing, which is second from the bottom, only 11% of policies made any mention of the budgetary or financial considerations of implementing these. On one hand, that makes sense because these are national policies, which are meant to be more at the strategic level and not the operational level. But as I will note in our lessons learned slide, we think that this is probably a major reason why we see suboptimal implementation of some of these policies and of some of the adaptations recommended in them. So finally, on to the lessons learned. So while our analysis of the policies was purely content-based, and that means we did not include in our research design any observation of the implementation of these policies. That said, based on conversations with colleagues, based on reviews of other research during this time and other implementation research in particular, we've been able to triangulate a few different pieces of information, both from our content analysis, but also from other work in this area. So I'll integrate that here into this final slide. So our first lesson learned from this work, or that we observed, was that indeed there was very rapid and effective policy development to develop these national policies to maintain essential health services at the start of the COVID pandemic in order to absorb and adapt to COVID shocks. And that was in part because of the rapid dissemination of global guidance from the World Health Organization and other technical agencies. And that was kind of one of the benefits of this process. We observed that one of the drawbacks perhaps was the lack of local engagement and participation, both of implementers and of citizens. And we think that the lack of engagement of implementers in particular may have been one of the factors that resulted in the suboptimal implementation of these policies eventually. So the next point we observed is that the content in the policies contain adaptations which could build towards longer-term transformation of health systems and primary health care. But again, as I mentioned, within the policies, there's a lack of operational guidance on how to implement and how to shift towards some of these more exciting adaptations that could truly improve people-centered primary health care. And as I also noted, we still don't really know which of these adaptations are effective or working, or even if they're being implemented at all. There is we have some information that these adaptations have been suboptimally implemented, again, as I mentioned from other research, but there hasn't been a systematic effort to understand which of these ideas have really gelled, which are working, and which should be continued. So we do recommend that to better prepare for future shocks and to continue responding to current COVID shocks, because they continue to persist, of course. Further work is needed to rapidly evaluate and identify effective and feasible adaptations, and then to operationalize and implement these policies at the lowest levels. So thank you very much for your time, and I'll pass it back to our moderators. Thank you.
Thank you, Jessica. It's very nice to hear a little bit in depth of your paper. I would like now to introduce Alexander Moran, who will talk about his paper about the tuberculosis in the Philippines.
Thanks very much. Let me get my screen shared here. Okay, great. So very early on in the pandemic, as Dr. Shearer described in her presentation just now, there was certainly a disruption in essential health services and sort of a lot of unknown. So in the context of tuberculosis, there were nearly immediate decreases in case finding, in treatment initiation, and in other relevant care indicators. Particularly in the Philippines, we sought to mitigate this disruption in the context of sort of closed health facilities and community quarantines. So today I'll be talking about our work at URC on maintaining essential tuberculosis services during the COVID-19 pandemic in the Philippines. The objective of this study was to describe the implementation, use, and cost of a phone-based tuberculosis case finding and case management intervention during the COVID-19 pandemic in 2 regions in the Philippines. For some context here, the Tuberculosis Contact Center is a low technology phone-based telehealth intervention based at 42 individual facilities with a tuberculosis basic management unit. The free service offers contact screening, diagnostic results delivery, adherence and treatment management, and adverse event management. And this intervention aligns with WHO priority actions for restoring tuberculosis services and serves as an additional point of contact to the health system. To sort of highlight some of our results, we found among 14 facilities with complete data, these facilities identified 9% of all people presumed to have tuberculosis, 44% of all confirmed tuberculosis patients, and 44% of all patients with bacteriologically confirmed TB who are enrolled in treatment among all interventions. So briefly, I hope you can see the cursor. In any case, I'll try to describe the picture here on the right. We have 4 different bars. The one most to the left is patients screened, then followed by presumptive patients, diagnosed patients, and patients enrolled in treatment. This lighter bar on the top is all other case finding activities in the facilities under study. And this darker bar at the bottom represents the Tuberculosis Contact Center specifically. So we note that the contact center accounts for relatively few screened patients, just by nature of the volume of other case finding activities. But as we move along the cascade towards identifying people who are presumed to have TB, people who are diagnosed with TB, and patients who are enrolled in treatment, we know that the contribution of the contact center increases across the cascade. So this intervention is sort of identifying a group at high risk for TB, or is selectively finding people who are in need of tuberculosis services. So this is an exciting finding for us to note that a very targeted remote service in which patients can call into the Tuberculosis Contact Center for contact screening or for other informational services, and for which our healthcare workers can call out to current patients for adherence support, for adverse event monitoring, and for other services, was effective in sort of reaching people who are at high risk for tuberculosis, or who are possibly at high risk for losing a connection to the health system. So over our period of analysis, which was 1 year, October 2020 to September 2021, we handled 6,187 calls. Most of these were outgoing from the healthcare workers to the patients, but there were certainly some phone calls incoming, either seeking diagnostic results, seeking information about tuberculosis treatment, or other related services. The other component to our study was looking at the cost of the Tuberculosis Contact Center. So to describe some of the methods, we used data on the cost of planning meetings, conducting training, buying mobile phones, buying initial and recurring airtime, and conducting awareness activities. We calculated the implementation cost for 12 months for a single facility, and we did not provide any reimbursement either for the use of the contact center nor for the training. So we sought to understand, because this is essentially providing services that are the standard of care, we sought to describe the additional cost of applying the contact center. And we found that it was low. It was about $7 additional to the standard of care per center identified patient. We identified 827 people with tuberculosis who started treatment among the 14 centers, averaging out to about $7 additional to the standard of care per person identified. And the entire cost to implement the center intervention in a single facility for 1 year in our study was just under $400. So just to sort of bring this together with some larger points and thinking to the future, the contribution of the centers to the efforts of screening and identifying people with tuberculosis increased throughout the care cascade, while the contribution of patients enrolled in treatment were similar to the share of people identified with confirmed tuberculosis. This means that we are identifying people at high risk for tuberculosis or are selectively screening contacts, and it means that our retention after identifying people with tuberculosis is high between identification and enrollment on treatment. The second point here says that the contact center intervention provides a strategy to reach the urban poor and rural populations who have less access to healthcare services and to technical solutions such as internet and mobile applications. With the center's specific scope, ease of use for patients, and clear reporting mechanisms, the centers benefit patients, providers, and the National Tuberculosis Program in the Philippines. Further, the intervention has the possibility of reducing barriers to care among those experiencing stigma, people who may have insufficient time or funds to reach a health facility in person, or people who prefer to communicate with health providers via phone instead of text messaging or a mobile app. And we think this really might have some applicability as we move forward through 2022 and onward to understand, is this an additional point of contact to the health system? And is this some additional way to access people who may have been missed otherwise by traditional health services? So to that end, additional work should assess the extent to which the contact center identifies tuberculosis patients previously missed by the health system, regardless of the pandemic. So I'd like to thank the Bulletin and the organizers for the invitation today, and I will turn it back over to the moderator. Thank you.
Thank you, Alexander. It was very nice to hear about your experience in the Philippines of reaching people who needs tuberculosis care. Now it's time for the question and answer that Dr. Viroch will moderate. So please, anyone who has a question, please come forward.
Thank you, Maria. To break the silence, can I ask a few questions to Alexander? On your contact facility, what specific activity you did through phone call, by screening the history, by inviting them for chest film or gene expert, as well as sputum confirm and culture? What actually you did? The second question to Jessica. This is one of the most exciting work, and you did the content analysis of national policy response to maintain essential services. Did you plan to follow up which year you did, 2020 or 21? Because it can be evolution of policy response, learning from the previous version of policy and adaptation, modification, as well as did you plan to conduct a repeat survey in 2020-22? These are two immediate questions to break the silence. Over to Jessica first. Lady first.
Thank you. Thank you so much for the excellent question. It's a great question in terms of whether we plan to follow up with the analysis to see whether there has been further revision and adaptation based on learning of these policies. We tracked the policies for about 1 year after we started this work. So about the first year of the pandemic, and we observed that most of the policies were developed very, very early in the pandemic. And in the first year that we tracked the policies, there were not many changes or adaptations to them. And so that had been one observation we had made in that first year, suggesting that there was indeed a need, because as we all recall, what we knew in the first months of the COVID pandemic evolved quite a bit, over the course of even the first year of the pandemic. And so we did recommend that there was need for further adaptation and revision of those policies. We stopped tracking after 1 year, but I believe that the WHO Pulse survey on essential health services includes a few questions related to this. And so we might be able to see change in trends over time. I don't believe, though, that they track a specific policy response. So I think that is a really interesting thing to do. I do think what would be interesting is to identify the countries that did revise their policies and did adapt their policies based on learning from implementing them, and do some type of a case study to understand how and why they were able to do that, and then exchange those lessons with other countries to encourage that type of learning, policy learning, Dr. Virat, that you mentioned. Thank you.
Thank you, Jessica. Alexander, you have any response to the question?
Yeah, thank you so much for the question. So there were really a broad variety of services. The incoming calls were relatively uncommon compared to outgoing ones. Incoming calls were mostly about information and seeking diagnostic results. But as far as the outgoing calls, our healthcare workers used these for treatment monitoring, so to check in on treatment adherence and sort of supporting treatment adherence and understanding adverse events if those occurred. Scheduling for testing or provider-initiated counseling and testing was the second most common. We also use this for treatment enrollment, as far as getting people who are identified with tuberculosis confirmed on, enrolled on treatment. And as far as the screening activities, these were mostly symptom screens, but it was useful to do this for contacts of people with tuberculosis. So someone who's been enrolled on treatment, these symptom screens for their households could be done via phone using this service, rather than sending a healthcare worker to the household during the community quarantine and lockdown situation. And then as far as other less common uses of the outgoing calls, importantly, there were sort of test result updates, sputum follow-up, and finally referral coordination. So this ability to sort of coordinate referrals and understand and maintain a connection to care and maintain continuity of care via phone for both providers and facilities, and also the patients, was really useful during this time to sort of maintain that single point of contact for managing referrals, which could be complex, especially during a community quarantine. So it's sort of a high level overview of the world of services that were mostly outgoing calls from this intervention.
So actually, the content of the intervention by your 42 facility is patient navigation.
A lot of it is. Yeah, sorry, go ahead.
Yes, it does not prevent a on-site face-to-face contact to correct sputum, chest film, etc., right?
Right, exactly. So the goal was to sort of anything that could be done remotely, as far as, like you mentioned, patient navigation and follow-up and treatment monitoring and contact management, was done through the phone service. Certainly enrollment, as far as actual provision of medications and actual collection of sputum, needs to be face-to-face to a certain extent. So these services were unable to be transferred fully to our phone-based system, but to the extent possible, any of the supportive services were migrated to this. And it was sort of the impressions, these aren't scientific necessarily, but the anecdotal impressions from the healthcare workers were very positive, and that it helped sort of alleviate the pressure of managing all of these services in person during a lockdown or something. So being able to manage these things via phone and to have more consistent contact with patients was well received on both ends.
Thank you. Jessica, if you look at the Q&A, one question directly to you, Jessica, can you respond from Sunil Meha?
Thank you, Sunil. That's a great question. My recollection is that the community category pertained to community health workers and other strategies such as that, whereas the community engagement was really focused on outreach or other strategies to engage community, so more of the demand side strategies. But I would have to clarify that. Thank you.
Thank you. Jessica, if you have a conversation with the virtual colleague, I see none in this participant set. The pulse survey, there are two pulse survey. It's very subjective assessment by national respondent. There's no quantitative measurement of how immunization was reduced by XYZ% of tuberculosis case detection. Therefore, it's time that the pulse survey have a more quantitative assessment rather than my estimation X% reduction, this interruption, etc. Any comment on that, Jessica?
Thanks. That's another great question. And I think we all know that it's been a challenging endeavor to try to measure and monitor these various things, including the disruptions to essential health services, but also the responses. And I agree with you, Dr. Virat, that it would be helpful to have clearer guidance for those responding to the pulse surveys in terms of how to respond and from which data to pull. I believe currently most respondents are looking at the national HMIS system, for example, for the questions on disruptions and entering information that they see in their national administrative data system on those disruptions. But then it does become quite difficult to connect some of that disruption data to some of the responses. And I think particularly with the responses, the survey respondents' answers have been quite qualitative, and it's difficult to confirm some of those sometimes. So I think that was the benefit of our approach, in that we did have access to all of these documents, and we were able to go in and code them all ourselves, which was labor intensive, but ultimately quite informative. And similarly, being able to either collect primary data or have a rigorous mechanism of looking at secondary data in terms of how countries are responding and whether or not that's working from kind of an implementation science perspective would be quite helpful. But if there are others on the call who have thoughts on that, I think that would be wonderful to hear. Thank you.
Before I return the floor back to Maria, a curiosity to Jessica, impact, how do you read Vietnamese, Cambodian, Malaysian, Bahasa Indonesian, Russian? How did you use Google Translation?
That's a great question. This is one of the reasons why we looked for policies in all countries in the world, but we ultimately in our database only had a subset of, I believe, about 60 countries, and that was partly due to language limitations. There were certain countries that we were able to include because we had colleagues who could read that language, and so we were very fortunate for that. And that pertains, for example, to the case of Vietnam, where PATH happens to have a country office. I would have to check, Dr. Virat, whether we included policies from Thailand, for example, or from Cambodia, but I do know that we encountered language challenges for a number of different countries' policies, which is a major limitation of this. Thank you.
Thank you. Back to Maria. Thank you. Thank you all.
Thank you so much, Leroy and Jessica and Alexander for sharing this. Yeah, I will give some final remarks, just saying from the bulletin that we have some upcoming theme issue. We have a rehabilitation theme issue in November, where the deadline of submission is 28th of February, which you can find more information on our website. And then the next after that will be the PMAC theme issue for 2023 that now the PMAC Secretariat will tell you more about. And yeah, thank you. Repipon?
Lapipong,
Hi, can you hear me?
Yes, we can.
Okay, is that Miss Hataychonok here?
Okay, this is everyone who you hear me?
Miss Hataychonok to present this.
Okay. For the potential timeline for submission of Bulletin of WHO 2023. So here are few. The issue of Bulletin call for paper for the theme of the climate change and health. And then the deadline of submission probably by end of July 2022. And then the launch of PMAC 2023 special theme in February issue of Bulletin 2023. And then Dr. Ratipong, can you give more information?
Okay, I would like to add on what Ms. Hataychonok already mentioned. Normally, the Bulletin of WHO has a long collaboration with the PMAC, and we use, like this event, we use the PMAC as a platform to launch the special theme of the Bulletin, which is related to the PMAC overarching title in that year. And for next year, 2023, it will be like the launch will be taken place in probably in late January or early February, up to the schedule of the PMAC. It is likely that the launch of the Bulletin in the February issue will be related to the special theme, which is also associated with the PMAC theme. And the PMAC theme next year will be related to climate change and health. However, the exact title will be launched or announced later. So far, we are in coordinating with the editor of the Bulletin in order to launch an editorial page, which is the call for paper, that the wider audiences will be able to see this in the April issue of the Bulletin. And therefore, we use this opportunity to announce you, to inform you in advance that it is very likely that the April issue will have the call for paper, so that you will have more time to prepare your papers if you wish to submit this to the Bulletin. And the deadline, normally the deadline will be set by the end of July or early August. So if you can prepare your papers in advance, which is related to the PMAC theme next year, and you may communicate with your peers or your working colleagues if they are interested to share their experience in or to share their knowledge or share their research findings to the bulletin, like the two authors that we invited, and they are already present here. So thank you, Dr. Virod and Maria. So over to you.
Thank you very much. I am very excited to handle this next theme issue. And I just want to clarify that the deadline is probably not the end of July, but the beginning of July. So we can get for the papers that need to be reviewed, we can get them out for review during the summer. So that's what I just had to add. And yeah, thank you everyone for listening. It's been great to be able to share this theme issue with you, and for the authors who've been here speaking, Jessica and Alexander, to hear some more in depth about your work. And Virod, you would like to say something more?
Yes, on behalf of Prince Mahidol Award Conference Secretariat, I must thank Maria for your continued support. Almost 10 years continuously, and we look forward. The quality of bulletin is very high. It enrich global conversation and drive public health agenda in many fronts. This has been shown for many years, for decades. Thank you, Maria. Thank you, the WHO Bulletin. Thank you, all the editorial team, and also authors who attend this session, as well as Jessica and Alexander. Thank you so much on behalf of the PMAC Secretariat. The meeting, the launch is adjourned now. Thank you so much, and have a nice evening, nice day.
Bye-bye. Thank you so much for coming.
Bye. Thank you.